for robotic water jet treatment, prostate size should be 30 to 80 cc. In prostate urethral lift, 30 to 80 cc prostate without median lobe. And in water vapor thermal treatment, 30 to 80 cc prostate, and for TUIP, less than or equal to 30 cc prostate. For TIPD, for temporary implantable prostate device, prostate volume should be 25 to 75 cc without median lobe. Prostatic urethral lift. Prostatic urethral lift marketed as a name by Neotrac or Teleflex, approved in 2014 by FDA. It can be done under sedation or local anesthesia. So it is a minimal mist, true mist. The AUA guideline recommended 30 to 80 cc without a median lobe. The FDA did approve the use of PUL for prostate size 100 cc up to 100 cc in 2020. It retracts the prostatic lock that allow outflow and minimizes the side effect of resection. The urethral end of the device is stainless steel, resistant to incrustation. The capsular tab is nitinol, and the two bars are tensioned by the permanent monofilament polyethylene terephthalate suture. There is BPH-6 study. It is a randomized trial. In 80 patients are enrolled and across 10 centers in Europe. Eligibility criteria were age more than 50 year, IPSS more than 12, Qmax less than 15, and volume of prostate is less than 60. The IPSS improvement remains significantly higher for TURP patients versus prostatic urethral lift, but differences between quality of life remain non-significant, and improvement in Qmax 15.8 in TURP arm and versus 5 ml per second in PUL arm. Ejaculatory men's health questionnaire of ejaculatory dysfunction scores were superior for prostatic urethral lift, but the MSQH EHD bother score is there was no difference. Retreatment rates at 2 year were 13.6% for prostatic urethral lift patients and 5.7% for TURP. There is another study, lift study. By 5-year results were given by the Rorbon et al. And it is a randomized control trial, Eurolift versus sham surgery. Eligibility criteria were IPSS more than 13, Qmax less than 12, and size 30 to 80 cc. Median lobe excluded. 206 patients included at 140 into UL arm and 66 in control. In this study, results were prostatic urethral lift superior to sham cystoscopic procedure, improve loads and higher health-related quality of life. Significant improvement in IPSS quality of life and Qmax at 3-year follow-up, but not in PVR. Prostatic urethral lift efficacy durable through 5 years with overall IPSS quality of life and Qmax improved by 36%, 50%, and 44% respectively. Surgical retreatment rate were 5% at 1 year and 10.7% and 3 year and 13.6% at 5 year. And most of the patients choose again PUL. PUL for patients with median lobe. There were a study, a MedLift study. The authors identified that IPSS quality of life and Qmax were improved. However, this study was excluded from formal analysis by the IUA because it was a non-randomized trial. Complications in BPS-6 study given by Songson et al. In 2015. Early adverse event seen in TURP, bleeding, and delayed phase urethral stricture and return of loads that were significantly higher in prostatic urethral lift arm. EAU guideline 2025 PUL improves IPSS, Qmax, and quality of life. These improvements are inferior to TURP at 24 months. And PUL has a low incidence of sexual side effects. Patients should be informed that long-term effects, including the risk of retreatment, have not been evaluated. And a recommendation of EAU offer PUL to men with loads interested in preserving ejaculatory function with prostate less than 70 ml and no median lobe. There is a video of PUL.
In a clinic setting, under local anesthesia, the urologist procedure begins by inserting the delivery device into the urethra. An inserted cystoscope provides the physician with visibility to the anatomy. On reaching the area of the urethra blocked by the enlarged prostate, they obstruct the tissues to move aside. A trigger press inserts a fine 19-gauge hollow needle through the prostate. The next trigger press deploys the implant, anchoring a small nitinol tab outside of the prostate, while retracting the needle attached to the nitinol tab is a little monofilament PET suture. The final trigger press completes the implant by placing a stainless steel urethral end piece onto the suture. Depending on the prostate size and amount of the blockage, several implants can be placed in the same way. Typically, 4 to 6 implants are placed into the proper clinic setting under local anesthesia. The neural assisted procedure again sutures tension. It also shows the prostate lobes to the side. This reduces pressure on the urethra and provides immediate visible results so urine can flow freely. It's a mechanical solution to a mechanical problem. The minimally invasive procedure requires no cut, heating, or tissue removal. This procedure avoids erectile and ejaculatory.
The next procedure is the prosthetic artery embolization. It is the endovascular procedure, injection of polyvinyl alcohol microspheres into selective prosthetic arteries. Femoral artery cannulated as the first step, and a prosthetic artery is identified, and 1.9 to 2.4 French microcatheters are inserted in prosthetic arteries, and embolizing agents, alcohol microsphere is then infused. The contraindication of PAE is a contractile or underactive bladder, neurogenic bladder, youthful stricture, bladder neck contracture, large bladder, diverticular stones, allergy to contrast dye, and chronic kidney disease. Um, the study for prosthetic artery embolization versus TURP for BPH, 5-year outcome by given by Malott et al. The improvement in LUTs at 5 years after PAE was inferior to that achieved with TURP. But post-operative erectile function are measured by IEF-5 questionnaire was in favor of PAE. This have fewer adverse events, 39% versus 77%. Shorter hospitalization time, 1.94 days, and but longer procedure time. And EAU guidelines, prosthetic artery embolization is less effective than TURP at improving symptoms and urodynamic parameters such as flow rate. Procedural time is longer for PAE compared to TURP, but blood loss, catheterization, and hospitalization time are in favor of PAE. And EAU says that offer prosthetic artery embolization to men with moderate to severe loads who wish to consider minimal invasive treatment option and accept to less optimal outcome compared with TURP, and perform PAE only in units where the workup and follow-up is performed by urologist working collaboratively with trained interventional radiologist for the identification of PAE suitable patients. The next therapy is the convective water vapor energy wave evaluation, also called the resume system. It uses a radio frequency power to create thermal energy in the form of water vapor. A small injection lasting approximately 9 seconds are performed transurethral using a handpiece equipped with a 30-degree optical lens. Release steam at a temperature of 103 degrees centigrade, creating circular dispersion and intraglandular lesion of about 10 mm. This process leads to the breakdown and death of the cell. Usually, 1 to 3 injections are needed for each lateral lobe, and 1 to 2 injection may be delivered into the median lobe depending on the size. Indications are 30 to 80 cc without a median lobe. The weapon needle penetrates the prostate at a fixed length of 10.25 mm and is deployed at the 3 o'clock and 9 o'clock position, starting 1 centimeter distal to the bladder neck, leaving 1 centimeter between injection sites to create contiguous overlapping thermal lesions distally until the proximal edge of the verumentinum. WT uses only 4 kilojoule of energy per procedure to produce cell necrosis, compared with the other therapies like TUNA, TUMT, and other laser availability techniques that use 250 kilojoules of energy. Uh, the study final 5-year outcome of multicenter randomized sham control trial of water WETT for treatment of moderate to severe loads, some secondary to BPH. given by the McAvery et al. It is a pivotal study of 197 subjects are enrolled and done in the 15 centers. The inclusion criteria were more than 50-year IPSS, age more than 50 year IPSS, more than 13 and prostate volume 30 to 86 without median low. In this study, IPSS at reduction in IPSS score in at 1 year 10.3 and at 5 year 11.1, Qmax by 15.2 at 1 year and 5 year by 14, and ejaculatory function at questionnaire at 1 year at 23 and 21 at 5 year, and BPH impact index at 1 year 2.3 and 5 year at 2.8. A percent improvement from the baseline in IPS is 48%, and the max flow is on 44%, and quality of life 45%. The complications were dysuria, hematuria, urinary frequency, and urinary retention. 5 year surgical retreatment rate were 4.4%, and 11.1% initial BPH medication, and objective outcomes PVR and max flow reflecting BPO relief were improved to the greatest extent after TURP, with moderate improvement after WVTT, and ejaculatory functions was maintained after the water vapor thermal treatment. It has a moderate recommendation. Evidence level is grade C. Water vapor thermal therapy should be considered as a treatment option for loads for 30 to 80 cc, and conditional recommendation evidence level is grade C for water vapor therapy may be offered to the eligible patient who desire to preserve erectile and ejaculatory function.
Unfortunately, there's some video frequency in sterile one paper, which again uniformly disperses through the tissue and into the state. The condensation of water is stored thermal activity. Cell membranes are connected in nature, thereby causing immediate cell death. Vasculature is closed, and there is denervation of the alpha adrenergic members within the treatment zone, providing you with an efficient, uniform, predictable treatment. Over time, this ablated tissue is resorbed by the body.
The next therapy is aqua ablation. This is image-guided robotic water jet ablation, also called aqua beam. Aqua beam uses the principle of hydrodissection. A targeted high-velocity saline stream ablates prostatic tissue without the generation of thermal energy under real-time transrectal ultrasound. The robotic handpiece is inserted transurethral, positioned proximal to the external urethral sphincter. The surgeon's only control variable is the speed and depth of the water jet, which is adjusted using a pre-treatment plan and a foot pedal. RWT only ablates posterior BPH tissue between 4 to 8 o'clock, and not a good option for a significant anterior prostatic tissue. This is the photos of image of RWT. There is a CPU and robotic handpiece, and there is a pedal here. There is a water trial 5-year outcome for aqua ablation therapy compared to TRP. This is a double-blind randomized trial in men with LUTS given by the Gilling et al. The eligibility criteria were IPSS more than 11, Qmax less than 15, size 30 to 80 cc. 181 patients were enrolled, and 116 in aqua ablation arm and 65 in TURP arm. There is a reduction in IPSS in aqua ablation arm, almost same in as compared to TURP, and quality of life is same. Max flow is increased in aqua ablation arm 125%, and reduction in PVR almost 62 ml in aqua ablation and 82 ml in TURP. And ejaculatory function, there were no ejaculatory dysfunction seen in aqua ablation, and in TURP minus 2.7. Adenoma retreatment rate were in aqua ablation 6% compared to TURP, which was 12%. But the operative time in aqua ablation 33 versus in TURP 36 minutes, almost equal. And resection time were in aqua ablation is 4 minutes versus 27 minutes in the TURP. And saline used is less than 500 ml, so there is no risk of TUR syndrome. In the water trial, RWT had superior safety outcome compared to TURP at 3 months, with an overall complication rate of 26% 42% in TURP respectively. Availability in but it has a very low availability at present, and in availability in commercial setting at present mainly in US and Europe. Better hemostatic techniques are being developed because there is a risk of hematuria. Handpiece insertion at times can challenge so because does not have a smooth beak. EAU 2025 aquila ablation appears to be effective as TURP both subjectively and objectively. There is 1B grade level of evidence is 1B. And offer aquablation to patients with moderate to severe loads at a prostate volume 30 to 80 cc as an alternative to TURP, weak strength. Inform patient about the risk of bleeding and the lack of long-term follow-up data.
Critical obligation of the procedures. They identify critical anatomy on all present. So it is a patient specific treatment plan. Providing the need for your that precisely follows the treatment plan. The reality receive prostate tissue is accurately and efficient and predictable time. The straight line will flow into the insertion of an ultrasound probe by a surgeon only state. This is system to be full system to visualize the anatomy as it is inserted for position in the middle and not to be fixating on. The entire process is visualized. The surgeon initiates treatment planning. Treatment planning begins by identifying clinical anatomy using purposes data to develop a plan specific to each patient. Business information managed for resection and will end as on a real-time evidence. The different protection zone is great to have accepted function. Like this is perspective, which the desired teaching and opposed the not kept, losing a five element while preserve the jacket for function. The surgeon maintains control of the resection with the entire procedure. Large extension is complete. The surgeon removes full the neck card using a percentage scope to follow existing moving vessels and line back. The minor approval is the next generation AI.
Next therapy is temporary implantable prosthetic device, also called iTind. The iTind is a nitinol device composed of three elongated struts and an anchoring leaflet. Under direct visualization, iTind is deployed inside the prostate by flexible or rigid cystoscope in light IV sedation, compress obstructing tissue by the expanded device, thereby exerting radial force leading to ischemic necrosis, and provide immediate relief from the loads without the side effects of permanent implant. TIP is made up of three nitinol struts at 12, 5, and 7 o'clock, and there is an anti-migration anchoring leaflet at 6 o'clock position. And there is a polyester retrieval suture for easy removal. Max diameter is 33 mm and length is 50 mm. TIPD is not recommended for patient with an obstructing lobe. The device is implanted for 5 to 7 days. The device is then removed after the treatment period by advancing an 18 French silicone catheter over the polyester suture and pulling the suture taut so that the TIPD collapses inside the catheter. The study for iTind is a temporary for a multi-center randomized control trial by Chuktai et al. The 185 patients are enrolled in 128 in TIPD arm and 57 in shams arm. Eligibility were aged more than 50 year, IPSS more than 10, Qmax less than 12 or equal to, prostate volume 25 to 75 cc. The IPSS improved IPSS improvement greater than the SHAM's procedure, and Qmax improvement 10.33 ml per second compared to SHAM procedure 5.3 ml, and quality of life improved better than SHAM procedure. Sexual function according to IEF and SHIM questionnaire remained unchanged in both groups. Reported as well tolerated by all patients. Complication scenes were yes. Complications seen were retention and transient incontinence due to device displacement and infection. 6 men had an alternative BPS surgery during the 12 months follow-up due to deterioration of symptoms. TIPD met the predefined primary outcome. However, the absolute difference in IPS at 3 months between TIPD and sham was not statistically significant.
Yes, the lower passes the bladder. The bladder was thinking of this, yeah, somewhere. Removing the objects, the imaging device, the configuration. And that's the lab. This is the genes.
Intraprostatic injections. Various substances have been injected directly into the prostate in order to improve loads, including botulinum toxin A, fexopatide trifluate, and PRX-302. The mechanism of action is through botulinum A toxin through the inhibition of neurotransmitter release from the cholinergic neurons. Injection preparation is the 200 units were diluted in 3 ml saline in lithotomy position and in thrust guidance. 22 gauge spinal needle were inserted transperineally and 1 ml solution injected in each lobe. Medical management continued up to 3 weeks. And EAU do not recommend the botulinum toxin injections for treatment of BPH. Drug-coated balloon dilatation is also marketed by the Optilium BPH catheter system. The system is comprised of two balloon catheters, pre-dilation and drug delivery balloon, to achieve immediate and long-term urethral patency. The pre-dilatory system delivers mechanical force to dilate the voiding channel and cause an anterior commissurotomy. The drug delivery balloon is then inflated and administered an antiproliferative agent, paclitaxel, to prevent the regrowth of the prostatic adenoma and scar tissue formation in the anterior commissure. The drug balloon is inflated for a minimum of 5 minutes and catheter is then placed for at least 48 hours. There is a trial, average trial for this, and complications seen were hematuria, incontinence, and UTI. Ejaculatory dysfunction also occurred in 8.8% patient. The original, only 1 year data is available for the average trial. The original Everest 1 trial, the drug-coated balloons were performed under GA or spinal block, but proponents of this system also aspire to perform the procedure in the office-based setting. TUVP, transverse vaporization of the prostate, given. Yes, we know it. Yes. TUIP in young male with a small size prostate who is concerned about the loss of ejaculation or future fertility. The decision given posterior laterally at 5 and 7 o'clock position, starting distal to the uretral office through the bladder neck and ending proximal to the verumentinum. The prostate surgical capsule is visualized, and some surgeon want to see the fat outside of it. The interprostatic incident given by the Fabian. This is alternative to an indwelling catheter in unfit patients. There are two types, temporary or permanent. The indications are elderly patients and frail patient who is unfit for surgery. And the urinary retention occurred as a treatment of by other therapies. There is a spiral stent and polyurethane stent and biodegradable stents. The permanent stents are a Urolium or Ultraflex. This is a woven tubular mesh that maintains its position in the urethra by outward external pressure, and original stent tended to shorten while it expand outward. This is the comparison of every therapy discussed here. The most costliest is aquablation. The take-home message: the MIST are provide effective alternative to TURP, but this is not a substitute for TURP. Careful selection of patient and shared decision making is of utmost importance to ensure optimal outcome. And long-term durability remains unlimited because patients should be counseled about possible retreatment. Thank you.
Thank you, Keshav. So we have discussed MIST procedures many times. This was a more detailed discussion on especially the MIST procedures in the management of BPH. We all know MIST means minimally invasive surgical therapy for BPH. And we have to understand what is its role in present scenario, and particularly in our circumstances, where the cost is a very important factor, right? And what is how effective it is. So the MIST, though they actually form a management in between the medical therapy and surgical therapy. So the basic aim of these therapies is to give a kind of a personalized treatment to a patient, a selected particular patient who may not be responding to the medical therapy or may not want medical therapy as the management. And the other who are not fit for surgical management or do not want surgical therapy either because of their high risk or because of their anxiety or fear of complications. So we need to exactly find out what is the place of a MIST procedure in today's scenario. The major benefits they think of MIST are: one is that there's a minimally invasive therapy. Secondly, the majority accept the aquablation. They can be done as a daycare procedure, as a OPD under local anesthesia with or without sedation. And they have less side effects or complications, as they mentioned, and particularly the sexual function, and that too the ejaculatory dysfunction. But the major limitations of MIST procedures being: one is that they are not as equally effective as other surgical, the standard treatment of TURP or the laser prostatectomy or LEP. Secondly, the chance of retreatment rate is quite high. Third, the failure rate is again quite substantial. And then the cost factor, which is again a very important factor. So these factors probably limit the use of MIST procedure in majority of the patients. So we need to exactly find out which procedure. So the few procedures that you probably, because these procedures were coming for last many decades. So we know the first, it came with intraprostatic injection of alcohol, and this was from our country, rather in our state only, somebody who started giving intraprostatic alcohol injection. And though it went into, became obsolete, was not recognized at that time. It must be around a half a century back. And then there are other therapies came in, like the transurethral microwave thermotherapy and the TUNA, transurethral needle ablation of the prostate, but all went into oblivion because they were not as effective as the standard treatment. So now we have basically two kinds of procedures: one which causes ablation of the prostate, and the one which helps by mechanical compression. So mechanical compression, one is the ITIN, the nitinol device, and then we have the intraprostatic stents, and then we have the mechanical compression by Urolift, right? And the intraprostatic stents also helps in improving the flow, particularly in patients who are not fit for any kind of surgery. And the tissue ablative therapy would be aquablation, the resume, and the water vapor thermotherapy, as said, and then the intraprostatic injection. And in intraprostatic injections, there are various injections besides Botox has come in. One is the intraprostatic ethanol injection, and there are other two chemicals. One is NX1203 and PRX302, which is also being researched has helped in causing tissue necrosis by intraprostatic injection. The another important missed procedure is the transperineal laser ablation of the prostate. So they have trying transperineally ablating the laser with laser, the ablation of the prostate. And then there is another procedure called histotripsy, where they, by high frequency ultrasound waves, they ablate the prostate. So histotripsy is again coming up. So these are various procedures which they do not have long-term kind of evidence, and we still have to wait to make it as a standard treatment. So this can only be given in a very selected patients who are willing to pay for that kind of a procedure, plus would be happy with a less efficacy than the standard surgical treatment. There are a few kind of a minimal invasive therapy which can be done with the same kind of a instrument and would not add to the cost, like the transurethral incision of the prostate in a very small prostates. Transurethral vaporization of the prostate we can do with a vapor electrode. We vaporize the prostate with the same instrument, bipolar and monopolar. And then we can put even intraprostatic injection with the same prostate, even Botox or alcohol ethanol injections. So these are some of these minimally invasive therapies which actually can be done under local anesthesia and sedation also, or sometimes intraprostatic block, and can give equal results with the newer MIS therapies. So I think we should understand and keep that also in our mind. I think this was in brief about the MIS procedures. If any of the faculty or resident would like to give any comment or has any query, they are most welcome. And people who are in the audience, those who have joined us today, are also welcome to make their comment. Nachiket, would you like to make a comment? Right. Yes. So prostatic, he discussed about the prostatic artery embolization of the prostate. Yes. Again, this is technically a little difficult because you have to go highly selectively to the prostatic artery, which may not be possible in every center. You need a very expert interventional radiologist to do this process. And still, we are not very sure about its efficacy and result as compared to the standard treatment. Yes, Adi?
Yes, so prostate useful surgery for the size of anchor, or the size of anchor is different or same.
Size of anchor means, okay, okay. So do these prostate urethral lift devices, are they of the same size or they come in different sizes?
The size you are supposed to mention.
So that is one of the limitations. One of the limitations that is in MIS procedure is they cannot be given in very small procedure less than 30-40 cc and more than 70-80 cc. So the standard thing is that they have to be between 40 to 80 cc only. So moderately sized prostate can only be dealt with the majority of these missed procedures. And then median lobe enlargement is again one of the limitation in missed procedures in majority of these. So I think the size remains the same, but you can, according to the length of the prostate, you can increase the number of pins, right? So very small prostate can have only 2 pins. Usually they give 4 pins, and sometimes you can add 2 more. So 6 pins open. So the cost increases. As
randomized controlled trial जो है सब 80 cc तक के लेकिन ये यूनिट 70 तक के लिए
allowed. So that doesn't make much of a difference. 70-80 cc does it? Anybody else?
Because yes, prostatic aspect, what material is used? सर कई गोल्ड प्लेटेड भी हैं आगे उसमें रिलैक्स से
So we have intraprostatic stents, we have biodegradable intraprostatic stents, biocompatible stents, and also metallic ones. So it started with Urolium, and then now we have Ultraflex. Why? So all these intraprostatic stents are no more used, more in majority. The newest one is Ultraflex, which is a biodegradable stent. It is used only in very sick patients where we just want to uh, allow the patient to void without catheter. So that's the only indication. One is the balloon dilatation, which has come up with paclitaxel therapy, as is for Optilute, as in for stricture cases also. They have used this balloon dilatation with paclitaxel. Um, anybody else? Yes.
Is there any
Diagnosis in terms of if the PSA is high, or if you think on rectal examination is a hard prostate, then definitely you need a tissue biopsy. Otherwise, yes, it's not required, mandatory. So again, one of the limitations of this is that you don't get a tissue biopsy in a majority of these patients.
Did you go through the Indian guidelines about the treatment of minimally invasive? Because there are guidelines about, I'm sure you discussed other guidelines. But this is one of the few set of which guidelines have been. Did you go through those?
I think very relevant that yes, there are few guidelines of national guidelines on various treatments. BPH guidelines also been made, male infertility guidelines, urinary incontinence patients guidelines. So all these are there on the website of USI. You should go through whenever you make a presentation, because we are more interested in our geographical conditions, whether it suits to our population or not.
Unfortunately, about these minimally invasive treatments that have recently come, like the mist therapy and the TIM therapy, iodine therapy, our guidelines are still silent just because they have not incorporated them in therapy. Our guidelines, I think they were made in 21, 22. And that is the whole problem, that every year the guideline panel does not sit inside and does not give their recommendation about these people. So it's important for you to also study about it.
Yeah, so one of the important things here also is that um, uh, though AUA and EAU has included missed procedures as guidelines, NIH probably doesn't include as a standard treatment and uh, prostate management. So we must think that these treatments are still under investigation, and the long-term results are still we are waiting for. Yes. I can't move the second slide. You see.
2-3 सालों से सर आई बीन फॉलोइंग गाइडलाइंस जैसे अपने क्लासेस में है studying. I am totally now understand that American European guidelines, they are totally industry driven.
Yeah.
They are totally industry biased, totally industry driven. The best example is the AUA. They will, for prostate cancer, they will change the guidelines at the drop of a hat. I mean, we should not blindly follow.
So yes, I think that you are very correct in saying, though they may not, our Western friends may not like it, but they have to accept the fact that but the whole management of these therapies is industry driven in quite a good way. So I think we should keep that also in mind. So we go to the MCQs. The first question is sham studies on urological procedures for low unit act symptoms due to BPH is frequently showing statistically significant decrease in AUA, are poorly tolerated by patients. What is the question? What is the question actually? Sham studies on urine. Uh-huh. Are poorly tolerated by the patient, have significant side effects, and should not be performed as a part of research.
Frequently shows statistically significant decreases in AUA symptom score.
have never shown a statistically significant improvement.
They frequently
It
show
also decreases the IPSS and
Okay, so you mean to say the shams to the placebo studies also reduces.
decrease.
So that's the placebo effect in almost every patient, right? Frequently shows a statistically significant decrease in AUS. So the probably the
Psychological impact of LGT.
yes, the
neurogenic control को उन्होंने बोला है कि
yes, the placebo effect is there in every therapy, and that is also in MIS procedure. So whenever we try to know the efficacy of a particular procedure, we must also know its placebo effect also, how far it is better than the placebo. Which of the following is true regarding transurethral incision of prostate? It commonly results in TUR syndrome. It is generally only used in prostates less than 60 ml. It causes retrograde ejaculation. It results in removal of large volume. It may have a lower rate of ejaculate discharge in patients when done unilaterally. So E, again, 2IP usually we do bilaterally, but unilateral incision has a less rate of ejaculatory dysfunction but I feel again it should be revised when we think of how the ejaculatory function is preserved. That whole principle is changed now. So if you are trying to make a midline incision from bladder neck to perimontanum, which cuts through that ejaculatory device, then probably the ejaculatory function will not work. So it's better to do on two sites, 5 and 7 o'clock, where you preserve that mucosa, which is 1.5 centimeter proximal to the perimontanum, which is responsible for ejaculatory process. So I think we should now revise whether just a midline incision can help to improve the ejaculatory function or not. Anyway, when using the prostate lift for treatment of lower urinary tract symptoms due to BPH, implants are placed where in the prostate anatomically. Okay, anterolaterally, posterolaterally, anteriorly, posteriorly in the peripheral zone. Yes?
Anterolaterally.
So more anterolaterally. So you saw those pins putting up anterolaterally more than right. And the reason was that to avoid the neurovascular bundles posterolaterally and the prostatic veins. And the implants work by primarily compressing the transition zone of the prostate and leads to an increased opening of the urethral lumen. Which of the following has the least sexual side effect among BPH surgical options? URP, HOLEP, Urolift, open prostatectomy. So Urolift, definitely. But again, when we talk about sexual dysfunction, the majority of these would say that the ejaculatory function is not compromised in MIS procedure. But again, I always am quite vocal about this thing as a complication, because one is that you have an ejaculation preserving TURP also, which was almost 80% ejaculation preservation. Secondly, what we are more important is in orgasm and not ejaculation. In a patient who is more than 50, 60-year-old, he is not worried about his ejaculation for fertility. He's worried about his orgasm and sexual pleasure. So orgasm and ejaculation are two different physiological processes. They are driven by two different mechanisms. And it's not necessary that the ejaculation, if is compromised, the orgasm will be compromised. Almost in majority, in 50%, the orgasm will not be compromised, even if the ejaculation is compromised. So we also should always keep that in mind. And most of this industry-driven MIS procedures, they make more stress on this ejaculation preserving, which probably could be a sham. Yes. So in the MedLift study, Urolift was evaluated for patients with neurogenic bladder, prostates with median lobe, prostates more than 120 cc, patients unfit for anesthesia. B, median lobe obstruction. So MedLift study. Okay, usually the Urolift, they say that the median lobe should not be there, but this particular study was done in patients with median lobe, and what was their outcome? So we do not have still the results of the, okay. In the water trial comparing equablation versus TURP, which outcome was observed? longer resection time for aquablation, higher complication rate in aquablation, similar operative times, aquablation associated with TUR syndrome. Which
Similar
outcome was a similar operative times? No, aquablation has a shorter arm.
Resection time is shorter.
Short resection.
35.
So resection time is shorter, but the total operative
Yeah.
time is almost the same. You have to dock in the robot and everything before the surgery resection starts. So they have a similar operative time and the others are not correct. In the pivotal resume trial, which of the following parameters did not significantly improve compared to baseline? IPSS, quality of life, Qmax, PVR. So Qmax is it? PVR. PVR did not improve in the resume trial.
PVR to आँख बंद करके है ना, this is that parameter that has never improved in the
Uh-huh.
last 100 years.
Uh-huh.
Our study में PVR was not significantly improved.
So PVR, unless the patient has a significant and good near retention kind of a thing, PVR is not a very important parameter for measuring the outcome or even the treatment or in the efficacy wise also. So I think that was the end. So if anybody has any other question, most welcome. Otherwise, we'll wind up the session.
Ejaculatory dysfunction, sir, अपन लोग तो we don't even ask any question to the patient before. I mean, usually we should, but है ना पूछते भी नहीं है. And they have AUA has ingrained ejaculatory dysfunctions as such a big issue that even in their guidelines for everything.
Yeah, so
I mean,
what
exactly.
so in every international kind of a CME or a conference, I usually stand up and ask this question, and nobody has even answered my question. When I ask them whether the person of a 60-year-old is important, ejaculation is important, the orgasm. So anyway, I think as you said, most of these procedures have a good part where is industry driven is in BPH.
You first of all should give permission
Yeah, what do you
before
want?
making any comment.
But in PBS study, they study the questionnaire MSH, Women's Health Questionnaire for Ejaculatory Dysfunction. There was a significant difference versus TURP and PUL. लेकिन bothersome score जो था सर वो remained unchanged, वो same था.
That is already there. So there is a special questionnaire, MHQ ejaculatory dysfunction questionnaire, which is different from the IIEF and the SHIM questionnaire. So when you are talking about ejaculatory dysfunction, and that questionnaire should be put, and in that, though there was a difference in the MHQ, but the bothersome score was same, right, in both Eurolift and pre-ops. Anyway. So if there's no other question, I would wind up there and have a good day. Thank you for joining our session. Can we stop it here? Just a second.